Okay, let's go over the anemia case study. I think it's really important that you listen to this. I really want you to do well on the next exam. There's different types of anemias, but we'll talk about this one. So, what are some clues here? Well, he's 72, so he is at risk for anemia. He's also has hyperlipidemia, so he's on a combination of lovastatin, which is a statin medication to lower cholesterol, works really well with LDL lowering, and niacin. Niacin works really well with HDL increase, because remember, HDL is happy and LDL is lousy. We don't want a lot of LDL, but we want more happy HDL. It also does really well with lowering triglycerides. Okay, so he's been having some heart pounding, short of breath. He's very fatigued. So if this patient comes in to see me, or even if it's inpatient, the first thing I do is like, one of the things on my list that could be wrong with him is anemia. We, us as providers, have something called a differential list. Differentials is basically when someone comes in and immediately starts talking to me. Mentally, I have a list in my head of everything I think it could be. So it's my job to try to figure out what's going on with this patient, starting with crossing out the most serious things. So as you move on, that's how we do it. So it looks like the physical exam was actually not bad. And if someone was anemic, sometimes you can look at the nail beds and they'll be really pale. So that's actually, I see that quite often. Sometimes you may not catch it, but it's a good physical exam finding. But many times you could do a physical exam and it's going to be completely normal. So now we have to go on and get some diagnostic studies, and voila, so this is what comes back. As you can see, his red blood cells are low, his hemoglobin is low, his hematocrit. It looks like he doesn't have an infection because his WBCs are fine. I don't see any bleeding disorders. His platelets are fine. But look at the MCV and MCH. If you watch my wrap-up video, it'll tell you what it is. So basically color and size. So the MCV and MCH helps me determine if this patient has an iron deficiency anemia or a microcytic versus a macrocytic anemia. I may not have any of this iron, ferritin, cobalamin, which is B12, or folate, because sometimes I'll just start with the CBC. Many of us do, and then we'll move on to iron studies. So if you pretend this stuff isn't here, I can look right away and say, oh, he's got a microcytic, hypochromic anemia. So right away, that tells me it's most likely iron deficiency anemia. But now I'm going to go on and get these studies. And as you can see that the iron is low, ferritin is low. Another thing I get is a total iron binding capacity, which I won't go into details, but it basically tells me how much iron, what the capacity of the room is. And I think I put that on my wrap-up video. Looks like this patient does not have a B12 deficiency or a folate deficiency. And if they did, it would be more of a megaloblastic or macrocytic anemia. These things would be elevated. So that's how we interpret that. So this patient has a microcytic hypochromic, microcytic hypochromic anemia. So that tells me it's most likely iron deficient. And what clinical manifestations? He's fatigued, dyspnea, palpitations, bounding pulses. These people are really tired. And if they have a sudden drop in hemoglobin, this person could be 12 and then end up being 9 within a week. They're definitely going to feel it. But if it's something that is gradual, as this case talks about with dietary, it's probably your body kind of compensates. So sometimes you don't really realize it until you're like, gosh, I have been tired lately now that I look back, and I am more short of breath. If you're looking at a sudden drop, you're going to have pronounced symptoms because your body is not able to compensate, that quickly, and that's most likely from blood loss. So iron deficiency and the probable cause, we talked about that. And with this cause, it's probably dietary intake. But we have to look. This guy is 72 years old. Anybody who comes into me and I diagnose a iron deficiency anemia, the first thing I need to cross off my list is whether you are actively bleeding and losing iron. So, and That's most likely in the GI tract. So many times I will get a stool for occult blood and see if they have blood. Are they losing blood that way? I look at their med list. Are these patients on NSAIDs to cause a possible a bleeding or erosion in their GI system? And this guy, I would probably look to see when his last colonoscopy was, to see if it's normal. I look at his medication list, and I may send him to GI for a colonoscopy and upper endoscopy. In the meantime, though, we can treat the iron deficiency by putting him on some iron. So, since he's iron deficient, we will need to do some teaching for dietary intake and eat foods that are good sources of iron. So, go to your dietary sheet here that is in your quizzes and exams. Make sure you memorize that and know what types of foods that they should be eating. So I'm just going over key points that are important. So what are some key points to taking oral supplements? So in the meantime, I'm putting this patient on ferrous sulfate. The usual dose is 325 milligrams of iron. I can write it as a prescription. They have it over the counter, but I just used to writing it as a prescription. It says 150 to 200 milligrams of elemental iron, which is equivalent to what the dose that I just told you. It's best absorbed if you take it by mouth. There are cases if someone has a low hemoglobin and has a history of low hemoglobin, or let's say, because I worked in a pre-op clinic, if someone is going for say uterine ablation because they're bleeding very heavily, which is another good point why patients can be iron deficient, women. Sometimes we send them for iron infusions. Not done too much, but it has been done to get their iron levels up and then get them to surgery. So as far as the medications though, know how to give iron. You will probably see this on NCLEX, may see this on exams. Take it with at least 8 ounces of juice or water. We think vitamin C, it absorbs really well with vitamin C, so orange juice is perfect. Now obviously if they're diabetic, you know, it's a different story. So we talk to them about just making sure that you're not taking it with antacids or milk. It's not going to absorb very well. And take it within an hour of meals because food decreases the absorption of the drug. So empty stomach, take with vitamin C because it enhances the iron absorption. And oral liquid can permanently stain tooth enamel. And if they need to take it that way, it needs to be given through a straw. Now, iron. It's normal to have black stools from taking iron. It's just part of the breakdown of the product. They can have some nausea, heartburn. I would say diarrhea is very, very rare. If anything, these are from it causes constipation, and because they take stool softeners, which is often recommended for these patients, that can cause diarrhea, and then we just tell them to back off. But these patients often have to take a stool softener stool softener or a laxative. I tell patients to start it once a day for a week, and then go up to twice a day, and then go up to 3 times a day. 3 times a day is the goal, and it will take at least a month to see any improvement. And if we look at the labs, the ferritin is the first thing that I'm going to see go up. I may see, because remember, red blood cells are recycled every 90 days, so I'm not going to see a huge increase in hemoglobin right away. It's going to be about 2.5 to 3 months. To see this rise in hemoglobin getting towards normal, but the ferritin goes up pretty quickly. So I will always get a ferritin in about 3 to 4 weeks and make sure that they're going up. In the meantime, I'm making sure they don't have a GI bleed, or if it's a female, is it heavy menstrual bleeding? And then I send them to gynecology. All right, anything else I want to say? There are certain herbal drugs that can decrease the absorption. So you just anything, remember when you're seeing patients or even in the hospital, look at their med list, anything. And patients, a lot of times when you ask them for their med list, they give you only prescriptions. So you have to always ask, do you have any herbal or over the counter? And then as far as nursing interventions, we talked about the diet. And then how are you going to know this patient is improving? Well, labs we will get, but remember, ask the patient how they're feeling. So they should be starting to have less fatigue, dyspnea, less palpitations. Hopefully within like the 3 to 4 weeks, they'll start having a little improvement in their symptoms. The fatigue may be there though for a while, because remember, again, we're trying to increase that red blood cell, hemoglobin, and hematocrit. And that's it.